بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, as we continue the series of pediatric imaging, we will discuss now one of the important subjects which deals with imaging of the pediatric intracranial infections. Then we have discussed this subject before whenever we talked about imaging of intracranial infection in the series of brain imaging. And the lesions are almost the same in the pediatric patient and in the adult cases, and we will discuss these issues from this point of view. You remember we have discussed the adult cases into these categories: the congenital lesions, and the issue of encephalitis, then cerebritis, granulomatosis disease, fungal and parasitic infection, and finally we talked about some of the HIV manifestations in the adult brain. Actually, I will discuss the same issues except for the last one, and we'll start by some of the basic informations about intracranial infection. And the first issue is we always need to inject contrast media intravenously whenever we are evaluating a case of suspected intracranial inflammation or infection. And this applies for the CT and also for MRI. Contrast injection is very important even if the lesion did not enhance after injection of contrast. This will help in the differential diagnosis. And we have two very common appearances after injection of contrast material. The first appearance is that we see here in an MRI image after contrast injection, where you can appreciate that the meninges covering the surface of the brain are thickened and enhanced, and this will help to diagnose meningitis. Then if you see an intraaxial lesion with a uniform marginal enhancement similar to this one, and you may think of an abscess. Then we'll start by the congenital or neonatal intracranial infection, which are usually referred to by the abbreviations the TORCH. TORCH stands for Toxoplasma, Rubella, cytomegalovirus, and herpes simplex virus. All these infections may occur intrauterine or during birth, and the appearances are almost similar on CT and MRI, and they will be commonly present by the presence of periventricular foci of calcification distributed everywhere in the cerebral hemispheres. Then these are the ways of transmission of the congenital intracranial infection. Number one is the bloodstream or the hematogenous route, and this will be the route for Toxoplasma and most of the viruses except the herpes simplex type 2. This virus is transmitted in the birth canal, and most of the bacteria leading to cerebritis will be an ascending infection during delivery. Then the presence of calcium in the periventricular area is usually suggestive of an intracranial infection, and this calcium or the distribution of calcium may suggest the type of infection. However, this is not conclusive. And it is always written in the literature that whenever you see periventricular calcium, and this calcium is intimately related to the wall of the ventricle, like this, what we call subependymal calcification, you may feel that this infection is due to cytomegalovirus. While if the calcium is haphazardly distributed with special or slight predilection for the basal ganglia, then you may think of toxoplasmosis. And if you see a brain scan like this with multiple foci of calcification scattered in the periventricular area of both cerebral hemispheres, then you may say that one of the differential diagnoses is the congenital intracranial infection, but you are not able to know which of which is the cause of infection. And toxoplasma is a protozoon which is transmitted by cat to the cattle, then to the human being. If it is transmitted by food, it will result in acquired infection which will affect mainly the chest. But if it is transmitted through the placenta, then it will result in the congenital infection which will affect mainly the brain. Then toxoplasma is a protozoon, and this infection may occur during the first or the second or the third trimester. And if it is late in the pregnancy, it will result in subclinical infection. And 10% of the patients will have hepatosplenomegaly, jaundice, and CNS manifestations. Of course, in the CT scan, you will see calcium, which is distributed around the ventricles, and also you may see hydrocephalus, which is commonly due to aqueductal stenosis. And this is a CT scan of a case of toxoplasma infection, where you can see extensive periventricular calcification and also calcium in the basal ganglia and calcium around the ventricles. You can also appreciate that the skull is relatively small, and there is a Dandy-Walker malformation in the posterior fossa in the form of a big retrocerebellar CSF containing cyst, which is communicating with the fourth ventricle through the aplastic vermis, as I have mentioned before in the lecture of hydrocephalus. And this protozoon is treated by antibiotics. And cytomegalovirus is one of the herpes viruses. It infects every person at some time of his life, and the infection of the infected pregnant woman may transmit this to the fetus. The infection occurs by bloodstream through the placenta. It will result in the same manifestations in the form of multiple periventricular calcification, but this calcium, in most of the cases, is intimately related to the wall of the ventricle occurring in the subependymal area. And this is a case of cytomegalovirus infection with CT scan showing evident periventricular subependymal calcium. It's worth to know that calcium of congenital intracranial infection is not usually seen by MRI. And this is an example. This is a female child, 2 years old, with cytomegalovirus infection. There are multiple subependymal periventricular calcium, which is well seen by the CT scan, while the images of MRI did not show the same manifestation. There are subtle low signal lesions in the wall of the ventricle, which may be suggestive of the presence of calcium. Then this is a case of cytomegalovirus infection in a patient with periventricular calcium. This calcium is located also in the genu of the corpus callosum. And here you can see calcium, which is away from the wall of the ventricle. I said that this is not a rule, the presence or the site of the calcium relative to the ventricular wall. Then to emphasize that small calcium is not usually seen by MRI, and this is another example. You see multiple foci of calcification in the wall of the left lateral ventricle, and this calcium is not seen at all in the T2 and the FLAIR weighted images MRI. And encephalitis means that there is brain infection by viruses, and the infection by viruses is usually related to the immune status of the patient. In patients who are immune suppressed or immune compromised are more liable for virus infection, whether they are children or adults. And you know, these are the major causes of immune suppression: the AIDS, then the cancer, and the organ transplant, which is usually followed by the administration of a long course of immunosuppressive drugs. Then these are the manifestations of viruses in the brain. There may be They may affect the meninges, resulting in meningitis, affecting the brain parenchyma, resulting in encephalitis, or affecting both, resulting in meningoencephalitis. And this is one of the form of viral infections of the brain, is known as acute demyelinating encephalomyelitis or ADEM. And there are other forms of subacute and chronic encephalitis. Then the symptoms of encephalitis include usually fever and headache, and some of these manifestations, such as lack of energy, dizziness, nausea, and vomiting, and some changes in the personality, and so on. Then encephalitis by CT will show non-specific findings. There are multiple hypodense areas. An MRI, they will show low signal in the T1 and high signal in the T2. And if you inject a contrast media in both CT and MRI, it is usual that you don't see any enhancement. But sometimes there is chiral enhancement after contrast injection. This is an example: female child, 8 years old, with a massive hypodensity in the left cerebral hemisphere and a smaller one in the right cerebral hemisphere, denoting the presence of uh, cerebral parenchymal lesions. In the good clinical settings, you are able to diagnose encephalitis. And this is also a case with non-contrast CT, post-contrast CT, and MRI FLAIR weighted image showing bilateral, non-symmetrical cortical and subcortical lesions with some post-contrast enhancement, and this is may be seen in some cases of encephalitis. The HIV virus may also affect the brain, resulting in encephalitis. And in this case, by MRI, this is T1 and this T2 weighted images. Then you can see multiple bilateral cerebral lesions of low signal in the T1 and high signal in the T2. And one of the well-known viruses affecting the brain parenchyma is the herpes simplex, and we have two types. Type 1, which is very common, and this is non-sexually transmitted. It is transmitted by the bloodstream, and it affects the children and adults. And the more severe one, which is sexually transmitted, it is rare and is transmitted through the birth canal, will result in neonatal encephalitis, and this will result in about 80% death of the neonate. And if the neonate is survived, 20% will suffer severe damage. And herpes encephalitis is has a certain imaging findings, which are the presence of lesions that specifically located to the medial part of the temporal lobe, and it is always said that biopsy of the brain tissue is not usually needed since the imaging findings are diagnostic. These imaging findings are in the form of lesions in the temporal lobe, especially the medial part. They may be symmetric or asymmetric. They are hypodense in the CT, low signal in the T1, and high signal in the T2 weighted image. And this is an example of unilateral pathology in the medial part of the temporal lobe on the right side. And this is an example of bilateral, almost symmetrical appearance of the lesions which show high signal in the FLAIR image representing herpes encephalitis. Then sometimes you can detect hemorrhage inside the herpes lesions. And this is an example you see by CT scan, a hypodensity in the left temporal lobe with a small hyperdensity representing a focus of bleeding. And in the MRI T1 weighted image, you see the low signal of the lesion and the high signal of the blood. And the lesion became high signal in the T2 and also in the FLAIR images. Then you are able in the FLAIR to see a small focus on the right side near the insula. This is a CT scan pre and post contrast of a patient with herpes encephalitis showing a lesion on the right side. And this lesion did not show contrast enhancement after injection of contrast. In the MRI, T2 and diffusion weighted images showed that there are bilateral pathology. The left-sided lesion was not evident in the CT scan, but it is seen well in the MRI. And this is also another case of herpes encephalitis on the left side. In the T1 weighted image, the lesion is not that evident, but you feel that there is some swelling of the temporal lobe with relative effacement of the cortical sulci and sylvian fissure compared to the opposite side. But after contrast injection, you cannot see evident contrast enhancement. But in the MRI T2 weighted image, you can appreciate the lesion, and also in the FLAIR image, you can see the lesion, and of course, in the diffusion weighted images, you'll see diffusion restriction. Then after a, a, a long time or a period of infection with management, then you will see that the brain will suffer too many lesions indicating severe brain damage. And this is are known as the late sequelae of encephalitis, or what we call post-encephalitic manifestations. In patients with previous viral encephalitis of the brain, the follow-up studies may end by disappearances where you got extensive hypodensities within the brain parenchyma, denoting areas of encephalomalacia, extraaxial, usually subdural collections, parenchymal and dural calcifications, and dilatation of the ventricular system, denoting the presence of atrophic changes. And this is what we call post-encephalitic sequelae, where there is almost total damage of the brain parenchyma on both sides. Only the basal ganglia appear intact. The ventricles are dilated and indicating the presence of atrophic changes. Acute demyelinating encephalomyelitis, or ADEM, is one of the viral infections of the brain, and it usually results in patches within the white matter, which are almost similar to the MS lesions in the brain parenchyma. And in order to reach the diagnosis, there should be a history of viral infection or flu-like attack or history of vaccination 2 weeks before the manifestations of this viral infection. And this will help you to suspect that this infection is due to ADEM or acute demyelinating encephalomyelitis. In this disease, you will see multiple batches of low signal in the T1, high signal in the T2 and the flare. These are flare images. And you see lesions in the cortex as well as lesions in the white matter. Then patients will complain of headache, drowsiness, and fever, of course. This is very important. And later on, they will develop some neurological deficits like upper limb weakness, lower limb weakness, seizures, and the condition may end by death. And this is a case of acute demyelinating encephalomyelitis with a follow-up after 1 year showing some regressive course of the disease. And this disease is a monophasic disease, so that you can able to differentiate these lesions from the lesions of MS. Acute demyelinating encephalomyelitis is diagnosed by the clinical picture of recent vaccination or a flu-like attack preceding the CNS manifestations by 10 days to 15 days. And these manifestations will occur in the brain and maybe also affect the spinal cord in the form of multiple batches of low signal in the T1 and high signal in the T2 and flare weighted, weighted, flare weighted images. And this is also a case of acute demyelinating encephalomyelitis with multiple periventricular foci, which are almost similar to the lesions of multiple sclerosis, but the typical clinical history, the presence of fever, the monophasic course of the disease are helpful in the differential diagnosis. And this is also the case of acute demyelinating encephalomyelitis, which cannot be discriminated from MS on the basis of imaging, since you see low signal in the T1, high signal in the T2 surrounded by edema, high signal in the flare, and after injection of contrast, and you can see this typical pattern of enhancing MS plaques, which is an incomplete ring or incomplete marginal enhancement. Then there should be a positive clinical history to help you to discriminate ADAM from the MS. And this is the history: progressive left hemiparesis after having had a viral infection a week earlier. And this is the clue. Also, the presence of fever is one of the pathognomonic features of ADAM, which is not present in cases of MS. And meningitis means that there is an inflammation of the meninges, and this inflammation may result from viral or bacterial or granulomatous infection. Of course, one of the common manifestations of meningitis is to result in hydrocephalus due to affection of the arachnoid villi, which absorb the CSF from the subarachnoid space. And also, being intimately related to the dural venous sinuses, it may result in sinus thrombosis, and this sinus thrombosis may also contribute to hydrocephalus, since it is the way for drainage of the CSF. And the patient may develop subdural or epidural emphysema, or the infection may extend into the brain parenchyma, resulting in infection, which may be in the form of encephalitis if it is due to viral, if the causative organism is a virus, or cerebritis if the causative organism is bacterial. Then you see the extension of the infection may reach the wall of the ventricle, resulting in ventriculitis and ependymitis. And this is a CT scan pre-contrast and after contrast injection showing extensive meningeal enhancement. So, okay, sorry for this interruption, and I will continue. And this is, as I have mentioned, this is a brain scan before contrast and after injection of contrast. Then you see enhancement in the sylvian fissure, enhancement in the quadrigeminal cistern, and this means that the patient had a, a meningitis. And this is also a case of meningitis showing enhancement of the quadrigeminal cistern as well as in the region of the basal ganglia. And this is an MRI T1 weighted image before contrast and after contrast injection. And you see leptomeningeal enhancement along the cerebellar folia. This fine linear enhancement also along the tentorial leaflets and within the circummesencephalic cistern around the brainstem in the suprasellar area as well as in the sylvian cisterns and also along the surface of the brain. This is diagnostic of meningitis. And you can see that the temporal horns of the lateral ventricles are relatively distended, representing denoting the presence of hydrocephalic changes. And this is a case of meningoencephalitis, affection of the meninges as well as the related cerebral tissue. In the T1 post contrast, and you can see this chiral pattern of enhancement. And in this diffusion weighted image, you can see the restricted diffusion in the involved parts of the brain parenchyma. Then, as I have mentioned, that sinus thrombosis will result in some cases in dural meningitis will result in some cases in dural sinus thrombosis, and this is a thrombosis of the internal cerebral veins as well as the vein of Galen. If you see this study, which is performed without intravenous contrast injection, and you can appreciate the hyperdensity of the vein of Galen, also the hyperdensity of the internal cerebral veins, and there is some hyperdensity in the region of the superior sagittal sinus in a patient with meningitis and obstructive hydrocephalus, then these are due to acute thrombus. And in the course of meningitis, accumulation of pus may occur in the epidural space like this one, or in the subdural space like this one, and this is a good example of subdural emboyema. The collection has a thick enhancing margin similar to the abscess. Then you should remember that there is no epidural space in the midline, and all lesions related to the falx and the tentorium are located in the subdural space. And this is a good example of a subdural emboyema in the posterior falx cerebri, showing low signal in the T1, high signal in the FLAIR and T2 weighted images with uniform thick marginal enhancement and this area of high signal is the reactive brain edema around the lesion. And this is the diffusion weighted image showing evident restricted diffusion. And this is an epidural abscess or empyema. You see the collection which is bordered by thick enhanced meninges. Whenever infection has reached the ventricle, it will result in inflammation of the ventricle with intense and uniform enhancement of the ventricular wall, and this is known as ependymitis or ventriculitis. Then this is a case of meningitis due to mastoiditis, and then the post-contrast image showed the extensive leptomeningeal enhancement over the surface of the brain. And after healing of the acute attack, the patient may develop a strial subdural collection, which is known as subdural hygroma. Then cerebritis is usually referring to the inflammation of the brain tissue secondary to bacterial infection. And this bacterial infection may reach the brain parenchyma by the bloodstream or from a direct extension from a nearby focus like the sinuses or the ear, or in some cases penetrating trauma or congenital heart disease with left to right shunt will lead to extension of inflammatory emboli to the brain parenchyma. Then in the early inflammation of the brain parenchyma, you got non-specific findings, and you see only an area of low signal in the T1 and high signal in the FLAIR weighted images, and it will show a restricted diffusion, and then there is significant surrounding edema. If you give a contrast injection like here, and you may not see appreciable enhancement. And you remember that this lesion may simulate the glioma, for example, but gliomas usually show free diffusion, and this lesion is showed restricted diffusion. And this is one of the helpful tools to discriminate between neoplasms and inflammatory lesions is the use of diffusion weighted images. After some time, then the area of cerebritis will liquefy to form an abscess. And the diagnosis of abscess is easy, where you can see a hypodense lesion with uniform thick enhancing margin surrounded by significant perifocal brain edema. The lesion will appear on MRI as low signal in the T1 and high signal in the T2 with a characteristic low signal margin surrounded by perifocal edema. After injection of contrast media, then you see thick enhancing margin, and characteristically this margin is of uniform thickness all around the lesion. And in the diffusion weighted images, you will appreciate the diffusion restriction. And brain abscesses may be small or may be large, may have a thick margin or thin margin, may result in the formation of daughter abscesses, and sometimes they appear multilocular, like this abscess in the left temporal lobe, and you can see that the contents of the abscess are of relative hyperdensity due to the presence of pus. And cerebellar abscesses are usually the sequelae of ear infection, and it is a good policy in the exams, in particular if you see a cerebellar abscess, and it's better to look to the ipsilateral mastoid and the middle ear, searching for an inflammatory lesion like this one, which is evident here. Then in the early stages of abscess formation, it has a thin enhancing margin, while later on the enhancing margin will be thick, but in all cases the margin will be of uniform thickness. And this is a good example of brain abscess in the right frontal lobe, showing high signal in the T2 with low signal margin surrounded by high signal perifocal brain edema. Then the lesion showed thick enhanced margin, and in the diffusion weighted images there is evident diffusion restriction. The complications of brain abscesses is the development of satellite or daughter abscesses like this one, and you see an abscess here with two small abscesses nearby, or also the abscess may extend to the ventricle resulting in ventriculitis or ependymitis, or may extend to the leptomeninges resulting in meningitis. And this is an example of an abscess in the left temporooccipital, in the right temporooccipital area that has extended to the ventricle, resulting in inflammation of the ventricular wall, and this is evident bilaterally with enhancement of the affected ventricles. And this is also a case of ventriculitis with enhancement of the ventricular wall, and the ventricles are dilated. They are almost transformed into abscesses. And this is also a case of ependymitis, where you can see thick enhancing ventricular wall on both sides. The ventricles are transformed into abscesses. Then we came to the granulomatous infection, and this will, in the pediatric age group, on top of these granulomatous infections is the TB, and TB may result in meningitis or encephalitis or result in the formation of tuberculomas or abscesses. Then if you look here for this CT scan, and you can see multiple small marginally enhanced lesions which represent tuberculomas, and these tuberculomas are sometimes surrounded by perifocal brain edema whenever they are in the form of active infection. And then this MRI axial T1 post contrast, then you can see enhancement of the basal cisterns, denoting the presence of basal meningitis, and the presence of multiple enhancing nodules scattered throughout the brain parenchyma, and these represent tuberculomas. Tuberculomas are characteristically small lesions with a thick enhancing margin, usually referred to in the books as the buttonhole appearance. But sometimes tuberculomas are large and they form tuberculous abscesses. And here you can see typical example of tuberculomas that are active in, as evidenced by enhancement of the wall and the presence of edema surrounding the lesions. And this is also multiple brain tuberculomata scattered in both cerebral hemispheres. And this is MRI of brain tuberculomas as shown by axial T1 weighted images after contrast injection. You see lesions in the brainstem and lesions in the temporal lobe as well as in the cerebellar hemispheres. As I have mentioned, whenever the tuberculoma is sizable and it contains a central hypodensity, then you consider it a tuberculous abscess. This is the original tuberculomas or the classic tuberculomas, and here an example of tuberculous abscess. And this is also an example of tuberculous abscesses. They are accumulated here in the region of the third ventricle as well as in the suprasellar area and in the temporal lobe. And also you can see the presence of subdural inflammatory collection in the left frontal area. And this is also a case of tuberculous meningitis with multiple tuberculomas. You see these tuberculomas with classic ring-like enhancement, and then the thick enhancement in the sylvian cisterns, in the suprasellar cistern, as well as around the brainstem. Also note the marked dilatation of the temporal horns of the ventricles, denoting the presence of obstructive hydrocephalus. And affection of the brain by fungi is usually the sequelae of impairment of the immune system. And the fungi will also produce the same changes like TB, including meningitis, encephalitis, and granulomas or abscesses. And for the diagnosis of meningitis, we see thick enhanced meninges in the post-contrast study. You cannot suggest the possible cause of this meningitis, whether it is virus or bacterial or fungal infection. But one of the helpful criteria for the diagnosis of fungal cerebritis is the well-known characteristic signal appearance of the fungus in the T2 weighted images. And you see here in the T1 weighted image, there are lesions of intermediate signal, and in the T2 weighted image, there is significant drop of signal intensity of the fungal lesions. And this is one of the characteristic criteria. But if you look here and you see an intermediate lesion in the T1 with this very dark lesion in the T2, you may suspect the presence of acute brain hemorrhage. But this post-contrast image will lead you to the correct diagnosis, since hemorrhage does not enhance with contrast material, and the fungal lesions will show this significant pattern of enhancement. And this is the case of fungal sinusitis with intracranial extension. In the T1 weighted image, the fungus is of intermediate signal, and there is significant drop of signal in the T2 weighted images, and you see the extension in the suprasellar area and in the right temporal region. And also you can see the evident post-contrast enhancement of the fungal lesion in the sinuses as well as in the intracranial area. Then we came to one of the known parasitic infections of the brain parenchyma, which is the cysticercosis. The cysticercosis is considered one of the common intracranial parasitic infections caused by Taenia solium. And the parasite will reach the body by ingestion of contaminated food, and it will reach the brain parenchyma and lodged in the brain tissue or in the meninges, causing intense inflammatory reaction. Then after the parasite dies, it leaves multiple foci of cerebral parenchymal calcification that are indistinguishable from those those resulting from the congenital intracranial infection. The active lesion will be like this one, a small lesion surrounded by prominent perifocal brain edema. The most typical appearance for cysticercosis on images, whether CT or MRI, is what is known as the cyst and the dot sign. And you see a cystic lesion with a dot inside, a cystic lesion with a dot inside, and this is one of the pathognomonic diagnostic criteria for cysticercosis. And the scolex or the parasite will appear within the cyst as a dot, and this is a CT image showing multiple cystic lesions with central dots. It is enough to see a dot within one of the lesions only. Then you consider all the lesions which do not contain dots belonging to the same pathology. Then the cyst and the dot sign is one of the helpful criteria to discriminate this lesion from tuberculoma, since tuberculoma do not contain a central dot, but the cysticercosis will have a thick enhancing margin and an internal dot sign. And the dot sign can be seen in CT, as you can see here, and also by MRI, as you can see. And this is one of the typical criteria for diagnosis of cysticercosis. And if you if you do not see or did not see the dot inside one of the cysts, you are not able to reach the diagnosis of cysticercosis. But here, if you look carefully for this cystic lesion and you can see a dot inside, and if you look carefully also here and you can see a dot inside, then you consider this secondary to neurocysticercosis. After healing of the disease, you are left with multiple haphazardly distributed periventricular calcific foci, giving the characteristic starry sky appearance. And this is not pathognomonic for cysticercosis. It can be seen in cases with healed TB and can be seen also in cases of congenital intracranial infection. And you see here multiple calcific foci scattered throughout the brain parenchyma for the differential diagnosis, including healed cysticercosis, healed tuberculosis, and congenital intracranial infection. And one of the parasites which is also known to affect the cerebral tissue is the hydatid cyst. And the hydatid cyst is diagnosed by an intraaxial lesion with clear water content, and there is no enhancement of the wall, and there may be some calcium in the wall of the cyst itself. And I think, in my opinion, the only intraaxial non-enhancing cyst is the hydatid cyst. And this is a good example for a cystic lesion within the brain parenchyma compressing the ventricle, and this is hydatid cyst. This is MRI of another case showing a bigger lesion in the right cerebral hemisphere, and this is hydatid cyst. And this is also a classic appearance of an intraaxial cystic lesion with some marginal calcification. Calcium can be seen in the wall of or inside the hydatid cyst. And finally, we came to a conclusion, or what we may say the take-home messages. And you remember that we have mentioned that diffuse meningeal or leptomeningeal enhancement is diagnostic of meningitis. Marginal enhancement of an intraaxial lesion is diagnosed of an abscess. If it is an extraaxial, you diagnose epidural or subdural empyema. Periventricular calcification is diagnostic of the torch infection, Toxoplasma rubella, cytomegalovirus, and herpes simplex, and also include healed cysticercosis and healed TB. Intraaxial cyst with no enhancement, in my opinion, is diagnostic of hydatid cyst. Bilateral temporal non-enhancing lesions are suggestive of herpes encephalitis. They may show some enhancement, they may show internal hemorrhage, but the temporal location and the clinical picture are usually diagnostic. Enhancement of the wall of the ventricle is diagnostic of ependymitis. If there is an intraaxial small cyst with a central dot, is pathognomonic for cysticercosis, the active form. The very dark signal of an intraaxial lesion in T2 weighted images is usually suggestive of a fungal infection. Thank you very much.